Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Medical marijuana is now legal in 23 states and the District of Columbia. What's the evidence that cannabis has therapeutic benefits? This is the People's Pharmacy with Terry and Joe Graydon.
Marijuana has been used to treat pain, nausea, and post-traumatic stress disorder. Cannabidiol oil is being tested for its ability to stop hard-to-treat seizures.
Dr. David Kassaret is a palliative care physician and professor of medicine at the University of Pennsylvania Perelman School of Medicine. He started as a skeptic on medical marijuana. His book is Stoned, A Doctor's Case for Medical Marijuana.
Coming up on the People's Pharmacy, find out how one doctor changed his mind on medical marijuana.
First, the news.
In the People's Pharmacy health headlines, drugs for heartburn may increase the risk for kidney stones. Millions of people take proton pump inhibitors like Nexium, Prilosec, or Prevacid on a daily basis. These drugs were once considered extremely safe. That's why the FDA has allowed them to be sold without a prescription. A new study has found that people taking these drugs are 12% more likely to develop a kidney stone than individuals who do not take such medication. They appear to reduce the kidney's ability to excrete oxalate and calcium, common components of stones. Another kind of acid blocker, H2 antagonists, was also linked to a higher risk of kidney stones. This potential increase in the chance of a kidney stone is modest, but it is worth considering. Perhaps people taking drugs such as cimetidine, ranitidine, lansoprazole, or omeprazole should be encouraged to stay well hydrated to counteract any risk of kidney stone formation.
Proton pump inhibitors have also been linked to kidney damage. A new study suggests that when people experience kidney damage, they may become more susceptible to cognitive decline. The researchers followed more than 2,000 people who had high blood pressure. Those who had more protein in their urine, an indication of poor kidney function, fared worse on their cognitive tests. Memory, attention, and executive function were all affected. Brain images showed that people with levels of albumin in urine had brain changes suggesting neuronal damage.
When people hear the word microbiome, they often think of intestinal bacteria. We now know that there are more bacterial cells than human cells in any individual person. What most of us don't consider, however, is the microbiome of the skin. We're teeming with microbes adapted to their own particular niche. One place in particular has a rich microbiome, and that's the armpit. This part of the body hosts a lot of bacteria, and the ecology of the bacterial communities in the armpit varies greatly between individuals. The study compared bacterial communities between people who use underarm products such as antiperspirants and deodorants and those who do not. There were striking differences. Not only were there many more bacteria in product-free armpits, the mix of species was quite different. Stopping the use of deodorants or antiperspirants resulted in an increase of bacteria that could be cultured. The dominant species still differed from those in armpits not accustomed to hygiene products. The authors are unable to say whether these changes have an impact on human health overall.
Flu season is starting slowly this year, but before long, people will be suffering with fevers, congestion, muscle aches and pains, and coughs. Some people may be much more vulnerable than others. A study published in the journal Science found that people born before 1968 may be less likely to fall victim to certain strains of influenza. That's because the immune system has a long-term memory. Viruses that were circulating decades ago may be similar to some emerging flu strains. The research in 1,400 people showed that children and younger people were more likely to get sick from H5N1. Presumably, older people didn't get sick from H5N1 because they'd been exposed in childhood to similar flu strains.
Researchers have come up with a possible explanation about the benefit that moderate drinking has for the heart. The study included 80,000 middle-aged Chinese people, studied between 2006 and 2012. At the beginning of the study, they were asked about their alcohol intake and classified as never, light, moderate, or heavy drinkers. Every 2 years, blood was drawn to measure cholesterol levels. All participants had a drop in HDL cholesterol during the 6 years of the study. The levels of moderate drinkers dropped most slowly, however. The researchers defined moderate drinking as 1 drink every few days for women and 1 to 2 drinks a day for men. They reported that beer had the most favorable effect. Moderate beer drinkers had the slowest decline in beneficial HDL cholesterol levels. Too few of these Chinese study participants drank wine to be able to judge its effect, while consuming hard liquor did not appear to be helpful. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. In the recent election, Florida, North Dakota, Arkansas, and Montana approved the use of medical marijuana. Research on its benefits and risks remains controversial, especially when it comes to therapeutic applications.
To help us understand the pros and cons of medical marijuana, we turn to Dr. David Casseret. He was professor of medicine at the University of Pennsylvania Perelman School of Medicine. He's now chief of palliative care at Duke University School of Medicine. He's the author of Stoned, A Doctor's Case for Medical Marijuana.
Welcome to the People's Pharmacy, Dr. David Casseret.
Thanks. It's great to be with you.
Dr. Casseret, you are what some people would refer to as a palliative care physician, meaning that, you take care of people, end-of-life issues?
End-of-life issues, certainly, but not only patients near the end of life. So palliative care is a specialty of medicine that provides help with decision-making, provides emotional and spiritual support, symptom management. In general, is focused on improving quality of life for patients with serious illnesses. Some of those patients are at the end of life, but many patients are 3-4 years away from the end of life. And some have chronic illnesses like heart failure that could go on for decades.
So how did you get interested in medical marijuana?
It was actually a patient of mine, a retired English professor, who asked me whether I thought medical marijuana might help her symptoms that she was suffering from due to advanced pancreatic cancer. And I gave her the stock answer that I learned in medical school, that marijuana is an illegal drug, it's addictive, there's no medical benefits. And she pulled out of her handbag several articles, randomized controlled trials of medical marijuana for the kind of pain that she was having. And I had to admit in that moment that this retired English professor knew more about medical marijuana than I did as a palliative care physician. So I promised her that I would look at those articles and I would do some research, talk to some patients, talk to some researchers, and give her a more informed answer than my first response about whether and how it might help her. And that's what led me to write the book, because I realized that if I, as a palliative care physician, didn't know much about medical marijuana, then probably lots of other physicians, lots of patients didn't know either.
Did she end up using marijuana?
It's a great question. Actually, she already was. When I came back to her a couple of weeks later and laid out the evidence and said, well, yeah, it's not legal in Pennsylvania, but I think it might help you, she said, oh, yes, it does. I've been using it for several months. It's provided me with a lot of relief. She didn't want to admit that up front, but she was using it and doing well the whole time.
Dr. Casseret, tell us a little bit about the history and what the archaeology tells us about the use of marijuana.
Well, what we know from archaeology is that people have been using marijuana for a long time. There was an archaeologic find in China that dates cultivated marijuana back 2,000 plus years. And the cultivated piece is important. Back then, it seemed like people weren't just harvesting wild plants, but people were actually cultivating it. People were selecting those strains and the female plants in particular that were high in THC. So going back 2,000 plus years, people were starting to use it, whether that was medically or recreationally or for spiritual or ritualistic purposes. We're not really sure, but it's been around for a long, long time.
And any of those possible uses are plausible, but without a time machine, we probably won't know.
We won't, although the best guess is since that find that I just mentioned was found in the burial urn of a shaman, the best guess is that there were probably some spiritual or medical uses.
Well, what I found so fascinating in actually doing a little research on the history of medical marijuana evolved from a question we received from one of the readers of our newspaper column. He says that he was born in 1933 and had asthma in his teens, and he was actually prescribed something called Rexall asthma powder, which he would actually light and inhale the smoke. And he thought it must be marijuana because it smells so much like marijuana. Well, doing a little research, I found that actually Rexall asthma powder had some anticholinergic ingredients like stramonium and belladonna. But in the 1840s and 50s, people did smoke marijuana for asthma, as well as a number of other medical conditions, including migraines and menstrual cramps. So when did doctors start prescribing marijuana for a lot of different ailments?
Well, the history dates back a long ways, probably, at least in more recent times. There's a physician named William O'Shaughnessy who was posted with the British East India Company to Calcutta in India in the mid-19th century, so mid-1800s. And he began to experiment with the use of various forms of marijuana, both smoked marijuana and hash and tinctures, which are highly concentrated forms of cannabinoids dissolved in alcohol. And he started to experiment with those forms of marijuana in the treatment of a variety of conditions, ranging from rabies to scarlet fever, as well as seizures and other disorders. His main contribution actually was figuring out how to create a tincture to essentially begin to medicalize marijuana, which then made it back to England a few years later and was widely promoted as a sleep therapy.
Presumably didn't do much for rabies or scarlet fever.
It didn't, probably, but it does have a calming effect, as many of us know, and certainly we're beginning to see increasing use of cannabinoids, cannabidiol, CBD in particular, for the treatment of seizures, pediatric epilepsy in particular. So it's interesting that 150 years ago, William O'Shaughnessy was interested in using cannabinoids, although he didn't understand what THC and CBD were, for the treatment of neurologic conditions, including seizures. And now we have randomized controlled trials going on right now for pediatric epilepsy. So history definitely repeats itself.
Yes, and we want to get more into that in a little bit. But first, tell us a little bit about Dr. John Clendenning in London, 1840, what he was doing.
Well, we're not entirely sure what he was doing. He became relatively well known because of a case report of a physician, he says, who remains anonymous, who used a tincture of marijuana for insomnia. My best guess, and this is just a guess, but my best guess is Clendenning knew so many personal details about this unnamed physician. And the unnamed physician, as near as I can tell, was exactly the same age as Clendenning himself, that this was a bit of self-experimentation. But he experimented with using marijuana in several forms, including a tincture for insomnia, and reported dramatic results that he had failed to achieve through a variety of other medications, including laudanum, which is a tincture of opium. So he really thought this was a home run.
Well, in fact, one of the people that you describe early in your book, Stoned, is a woman you call Alice, who has been playing Scrabble with herself in the middle of the night because she can't sleep. And she is hoping that marijuana will provide the pathway to sleep that Ambien hasn't. Any reason for her to be hopeful about that?
Well, it's interesting. It's one of the most common uses for medical marijuana for insomnia. There's not good randomized controlled trial data. Nobody, to my knowledge at least, has done a randomized controlled trial of marijuana in any form for sleep. Most of the data, and there is actually a fair amount of data out there, come from other studies. For instance, people with pain or nausea who use medical marijuana for those symptoms and then find as a somewhat desirable side effect that they're sleeping better. So there are a lot of those sorts of data. I certainly wouldn't be surprised if Alice found some benefit, although it's worth pointing out that she turned to medical marijuana after trying lots and lots of different things, which is not that unusual in my experience.
What I find fascinating is that there is a whole sort of medical scowl that happens when you talk about medical marijuana that doesn't happen when you talk about prescription drugs. So, whether it's Ambien or Ativan or Xanax, doctors have prescribed these sleep aids for decades, tens of millions, hundreds of millions of prescriptions. And even though there is now some data to suggest that they may have an impact on cognitive performance, most people go, well, it's just Ambien. It's just Xanax. Don't worry about it.
Well, and that they don't work all that well either.
And they don't, if you look at the clinical trials, they're not that effective. And yet if the word marijuana is mentioned, it'll cause all these problems, mental illness, people won't be able to think clearly. I mean, certainly you would never want to prescribe marijuana for chronic insomnia. Why the double standard?
It's fascinating. And by the way, I love that phrase, a medical scowl. I will use it and attribute it duly every chance I get. I really do love that. I think that's true. And a medical marijuana activist by the name of Clint Werner, who has been writing about the subject for decades, coined a wonderful phrase, which I also like, which is euphorophobia, which refers to the general reaction of the medical profession to any drug that makes you feel good, which we also see, frankly, in physicians often their reaction to opioids, which are very effective in treating pain, but also which make people feel good. And physicians are reluctant to prescribe often. I see that chronically in some of my patients with advanced cancer pain whose physicians don't want to use opioids. So I think that's part of it. Add in all of the counterculture references to marijuana dating back to the 60s, and I think you have a potent mix of ingredients that lead a lot of physicians to say it's basically just a joke. Medical marijuana is a joke, which is what I thought, honestly, when I first started researching this topic.
You're listening to Dr. David Kausrat. He's professor of medicine at the University of Pennsylvania Perelman School of Medicine and director of hospice and palliative care for the Penn Health System. He's author of Stoned, a doctor's case for medical marijuana.
We need to take a short break. When we come back, we'll find out why people worry so much that a patient might feel euphoric on marijuana.
We'll also delve into the different marijuana compounds that may have therapeutic effects.
What's the state of the science behind the use of medical marijuana?
Why has there been so little research into treatments for intractable seizures or neuropathic pain?
Marijuana is classified as a Schedule I drug. What does that mean?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Intranatural's nutritional supplements. Information on how they're redefining nutrition can be found at intranaturals.com.
And by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
If you would like to order a CD of this show, you can call 800-732-2334. This is show number 1027. That number again, 800-732-2334, online at peoplespharmacy.com.
Today on the People's Pharmacy, the topic is medical marijuana. Does this ancient herb have a role in modern medicine?
We're talking with Dr. David Casseret. He's professor of medicine at the University of Pennsylvania Perelman School of Medicine and director of hospice and palliative care for the Penn Health System. He's author of Stoned, A Doctor's Case for Medical Marijuana.
Dr. Casseret, you mentioned euphorophobia. So this is something that I think physicians learn, if not in medical school. Certainly there's a kind of culture of medicine that says if something makes you feel good, then maybe you should, wag your finger and scowl and shake your head in dismay because you don't want patients to feel good. I mean, that's sort of scary. But a cancer patient at end of life in pain, why shouldn't he or she feel good? Why shouldn't, in addition to getting rid of the anxiety and the stress and the pain and the nausea and the vomiting, be a euphoric effect that might help in the process? So explain to us, if you will, where that euphorophobia comes from and why euphoria might not be such a bad thing at end of life.
Sure. Great questions. I think when Clint Werner coined that phrase, euphorophobia, I think he was referring to a general reluctance of physicians to prescribe medications that were mostly intended to make people feel good. And I would cut physicians a little bit of slack since I am one. We do get requests, as many physicians know, for patients who come to us asking for, say, opioids without a clear medical indication because they just want to feel good because they're addicted. I'm not saying that's the majority of patients, but there is this fear, I think, of many of my colleagues, and I'm susceptible to this too, I think, that we don't want to be hoodwinked into prescribing a medication that either is unnecessary or worse, will fuel an addiction. Again, not common, but none of us really wants to be in the position of doing harm and contributing to addiction. So I think there is some legitimate reason behind physicians' reluctance to recommend anything that makes people feel good. Sometimes, often, I think in my experience, that reluctance isn't rational, and it causes us many physicians, not to prescribe medications we should have. And end-of-life treatment is probably one of the best examples of that. I think many of us who are skeptical and worry about the downstream consequences of prescribing opioids for somebody with chronic pain realize that for somebody in the last weeks or months of life, addiction, those sorts of concerns really aren't an issue. And the primary concern, and this is what we try to teach our medical students and residents, the primary concern is making people comfortable in a way that's rational, logical, and safe, obviously. But people's comfort and quality of life really becomes the primary focus for patients and families, and it should be the primary focus for patients, physicians.
The idea of getting high with marijuana has, I think, held back a lot of the research. Could you comment?
Tell me more about what you mean by a fear of getting high.
Well, I suspect that physicians would be more comfortable prescribing marijuana for the nausea and the vomiting associated with chemotherapy if people didn't also get high if they were to smoke it.
Yeah, that's a great point. In fact, you can go back to the 70s. There was a drug called nabilone, which is a synthetic form of THC, or a synthetic cannabinoid related to THC. And the testing process that went on as nabilone was being developed was to try to figure out whether it might have some of the medical benefits of THC without those euphoria effects. So it was really a designer drug that was designed to provide some medical benefits without that undesirable, at least to the researchers who are developing it, that undesirable feeling of being high. So yes, I think there probably would be a whole lot more interest in synthetics or forms of marijuana, for instance, those that are low in THC and high in cannabidiol or CBD, that don't have those euphoria-inducing effects. I think if marijuana looked a little bit different and had that different profile, it would be much more popular in the medical community right now.
Now, you've been, I'm sorry to say, throwing around a few acronyms, THC, cannabidiol, which is not an acronym, but it is a long word. Can you explain, please, what you're talking about, just in case some of us aren't familiar with it?
Sure. So in a typical marijuana flower, there are lots of cannabinoids. So-called cannabinoids are molecules that have a similar structure and bind in similar ways to receptors in the brain and the body. Of that class of molecules, so-called cannabinoids, the two most common, the two most prevalent in a marijuana flower, and by far the best known and best studied, are THC and CBD. So THC is tetrahydrocannabinol, CBD is cannabidiol. Those are kind of the stars of the cannabinoid world. Of the two, THC, tetrahydrocannabinol, is the one that's responsible for those feelings of euphoria, feeling good, feeling high, also responsible for some of the negative effects that sometimes people experience with marijuana, like agitation, anxiety, paranoia, confusion. CBD, or cannabidiol, is kind of the quiet cousin to THC. It doesn't cause any of those euphoric effects. Even in very, very large doses, you don't feel any different psychologically, nor does it, as near as we can tell, have any of those negative psychological effects. What effects it has medically are a little bit less certain, but there's a lot of interest in the role that CBD, cannabidiol, might have in treating neuropathic pain, which would be the holy grail for some physicians, at least. It would be a cannabinoid compound that has medical benefits, but which doesn't cause that euphoria effect.
Explain, if you would, neuropathic pain. We see commercials on television for a drug like Lyrica, for example, that is supposed to take away the pins and needles, burning, the sensations sometimes associated with diabetic neuropathy. Is that what you mean? And how would cannabidiol work?
Well, we're not really sure how it works, but a lot of patients I talked to, including one woman who was a very successful businesswoman, ran a chain of boutique stores, was injured in an accident and spent several months in the hospital, emerged able to walk, able to function, but with bad neuropathic pain. And neuropathic pain refers to pain that's caused by damage to the nerve itself. So unlike normal pain, that's a normal response to inflammation or tissue damage, like a broken leg or a sprained ankle. Neuropathic pain is caused by malfunction of the nerve itself, which happens sometimes after trauma, after a battlefield injury among veterans, sometimes with conditions like diabetes or lupus. But neuropathic pain stems from damage to the nerve itself. And so unlike regular so-called nociceptive pain due to a sprained ankle, neuropathic pain tends to be very, very difficult to treat. It doesn't respond well to opioids like morphine. People who use opioids like morphine often get some relief, but often wind up with a lot of toxicity and side effects. It makes them feel stupid and slow and goofy and confused and sleepy. And so there's a lot of interest in the pharmaceutical industry in coming up with other treatments like gabapentin, like Lyrica, which you mentioned, to try to find other treatments. And many patients, like the woman I just mentioned, turn to the use of marijuana after they had tried dozens of other medications and had nasty side effects and lack of benefit. So a lot of people are turning to marijuana for treatment for neuropathic pain because the drugs that are available either over the counter or by prescription just have an unfavorable balance of toxicity and side effects, and they just don't work.
That's a super story. Is there any science to support the use of marijuana for neuropathic pain?
Yeah, there is. And there's actually probably, to my way of thinking, as much or more science to support the treatment of neuropathic pain than there is for any other condition. And a lot of that research comes from an anesthesiologist named Barth Wilsey, who is an anesthesiologist, pain researcher at UC Davis in California. And he's gotten interested over the last 10 years in the treatment of neuropathic pain. And earlier in the interview, I told you about my patient, the retired English professor, who came to me with neuropathic pain due to pancreatic cancer, pulled a couple of articles out of her handbag to show me. Those articles were by Dr. Barth Wilsey, and I got a chance to talk with him as I was researching this topic. And he's very interested in the role that marijuana could provide for neuropathic pain in particular. And he's found pretty dramatic improvements in neuropathic pain, which is particularly impressive because, as I said before, neuropathic pain is really hard to treat. So if you've got something like marijuana, whether it's smoked or vaporized, that actually begins to show an impressive effect, that's potentially very valuable to a lot of patients who aren't finding good relief with the medications they're using now.
Dr. Kasserat, there is at least the rumor that medical marijuana, can be helpful for intractable seizures. And there are reports that a number of parents have taken their children to Colorado, for example, to be able to have legal access. Is there any science to support that?
Yeah, there's some. And some of that science has actually been around for a long, long time. Raphael Mechoulam, who I had a chance to meet, is an Israeli scientist, arguably the grandfather of medical marijuana science, did some research on childhood seizures way back in the 70s. Very small preliminary trials that began to give some evidence that some components of marijuana, whether it's THC or CBD or maybe both, have an effect on seizures. As I was researching this topic, I had a chance to talk to two parents of a young girl named Randy, who they were giving a concentrated cannabidiol or CBD oil for her seizures. She had a condition called Dravet syndrome, which is associated with onset of horrendous seizures, often at the age of 6 or 9 months. Randy, despite multiple medications, multiple neurologists involved in her care, was having sometimes several seizures a day. They started her on the CBD oil, and the frequency of her seizures, they said, went down to once a week. And I got a chance to meet Randy, and she was happy, healthy, playing, engaged in conversation with her cat named Buster, and leading an almost normal life with the help of this CBD oil. I should clarify that, to my knowledge, there haven't been good randomized controlled trials yet. There's a neurologist named Oren Davinsky who's doing exactly that trial. He's based at New York University in New York City, and those results should be out hopefully in the next, I guess, 6 to 12 months. But a lot of parents, like Randy's parents, swear by it.
Dr. Kasserat, you begin your book, Stoned, with a description of a man you met who's living in a mobile home, a man named Caleb. He's a blacksmith. Can you tell us a little bit about him and why he starts the book, please?
Sure. Caleb had an amazing but also sad story, and it was that story that really was one of a couple of factors that led me to rethink my vision of medical marijuana and what it does. So Caleb was in his 40s, kind of an unusual soul, marched to the beat of his own drummer, was homeless for a period of time, worked as an itinerant blacksmith, walked across the United States because he had always wanted to do that, had lived a very varied life, and was diagnosed with colorectal cancer when he was in his early 40s. Went through some treatment, wasn't curable. He was having severe pain, also with a neuropathic component, partly due to chemotherapy, partly due to radiation therapy and surgery. And the only thing that helped him was marijuana. And he would smoke the equivalent of several joints a day, but had trouble getting it in the state in which he lived. And so he went to Colorado to enroll in a hospice that he had heard provided marijuana to its patients. He was very, very poor, couldn't afford to buy it, and was disappointed when he found out that this hospice, due to legal reasons, actually wasn't able any longer to provide marijuana to its patients. And I went to visit him in a trailer outside of Denver in Colorado, and I was struck both by the stories he told me of how much marijuana helped him, but also how much more it helped him than the other drugs that the hospice physician prescribed. He showed me a box of medications, including things like Ativan and morphine, sitting there in his trailer in a box, untouched. because they didn't help him. What really helped him was the drug, as he called it, the drug that he couldn't get, the drug that he couldn't afford, which was marijuana. So this was a guy who wasn't trying to get high. He wasn't trying to get stoned. He really thought of marijuana as a drug, the drug that really helped him more than this entire box of other legal prescription medications did. And that really shaped my thinking, and that's why it starts the book. That's really shaped my thinking about what medical marijuana is, and got me thinking that it really is, to many people, a medicine that science and physicians should begin to think about more seriously.
Why do you think there has been so little research into the basic treatment of conditions that you've already talked about, whether it be intractable seizures or neuropathic pain or even just end-of-life cancer patients? It seems like a lot of physicians say, well, I can give you medicines, real medicines, FDA-approved medicines, but I'm uncomfortable with marijuana.
Well, it's important to clarify that question a little bit. There has actually been a fair amount of research, but a lot of that research, most of that research, has happened outside of the United States. So Raphael Mechoulam, arguably the grandfather of medical marijuana science, has been doing this work back as far as the 60s. The more interesting question, I think, and the way I'd reframe it, is why there hasn't been more research in the United States. Medical marijuana is now legal in 23 states, plus the District of Columbia. By most counts, there are several million people using it, although there haven't been good randomized control trials for many indications here in the United States. And I think that's a real problem, obviously, that people are using it without studies to guide that use. And some of it comes down to stigma, but a lot of it has to do with the way that marijuana is scheduled. It's a Schedule I drug. It's up there with heroin.
So a Schedule I drug means what, please?
A Schedule I drug in the FDA coding scheme means it's a drug that the FDA and the government have decided doesn't offer medical benefits and poses significant risks. So, as I said, another Schedule I drug is heroin, which we think of as being addictive and dangerous with no medical uses. Although I should note that sometimes those criteria are in the eye of the beholder. If you go to England, one of the drugs on the national formulary is a drug called diamorphine, which the national formulary has decided poses some risks but offers significant benefits in terms of pain management. Diamorphine is what we know of in the United States as heroin. So heroin in the United States is a Schedule I substance that's addictive and dangerous and non-beneficial, but just a 6-hour flight across the Atlantic, it's used in pain management.
You're listening to Dr. David Casseret, Professor of Medicine at the University of Pennsylvania Perelman School of Medicine. His book is Stoned, A Doctor's Case for Medical Marijuana.
After the break, we'll find out how marijuana may be used for pain and to calm agitation among Alzheimer's patients. There are a number of ways to take marijuana. Which is best?
We'll also find out about side effects.
And we'll learn whether marijuana is addicting.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redx Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel soft and smooth. The number is 800-345-7339. The website is uttercream.com. And
by Intranaturals Nutritional Supplements. Information on how they're redefining nutrition can be found at intranaturals.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1027. That number again, 800-732-2334, online at peoplespharmacy.com.
Today, we're talking about whether there's a role for medical marijuana. Our guest is Dr. David Casseret, professor of medicine at the University of Pennsylvania Perelman School of Medicine. He's also the director of hospice and palliative care for the Penn Health System. His book is Stoned, A Doctor's Case for Medical Marijuana.
Dr. Kasserat, the use of marijuana for pain, you mentioned neuropathic pain. Does it help for any other pain? And I'd also like to talk a bit about a condition that's really common, and that is the agitation associated with Alzheimer's disease and other dementias. You went to Israel and visited Zach Klein, who deals with a lot of nursing home residents there. And, we're stuck with this terrible paradox of the antipsychotic drugs that are prescribed but can also kill older people. So help us understand, number one, pain, and then number two, dementia, and where THC might have a role there, or cannabidiol.
Sure. So the pain story is really an interesting one. I met a couple of patients, several patients actually, who used marijuana for neuropathic pain. Not many who used it for regular chronic nociceptive pain, say due to long-term back pain. And I think we don't really know whether it works for more common run-of-the-mill pain. Mostly because most of the studies that have been done by Bart Wilsey and others have focused on neuropathic pain, because that's the pain that's really hard to treat. That's the pain, when I see neuropathic pain as a palliative care physician, I say, oh no, this is not going to be an easy home run, fix the problem, get people feeling better with a low dose of opioid. This is going to take a lot of different medications and a lot of titration. So it's neuropathic pain that really has gotten a lot of attention. It may turn out that marijuana is effective for more common run-of-the-mill pain, and maybe more common run-of-the-mill pain that has a slight neuropathic component to it. But right now, for my money, I think the best evidence is for neuropathic pain. You asked also about the use of marijuana or cannabinoids for the management, the treatment of agitation in patients with dementia, those particularly in long-term care facilities and nursing homes. I had a chance to meet Zach Klein, who is not a medical marijuana researcher, not a physician, not a biochemist. He's actually a filmmaker in Israel. And he got involved in the medical marijuana movement in Israel when he helped his mother, who was dying of cancer, get access to marijuana, saw how much it helped her, and began volunteering in nursing homes, helping nursing home residents to get access to medical marijuana, particularly nursing home residents with advanced dementia. Marijuana smoke seemed to help those patients with agitation and dementia calm down, became less agitated, less likely to get up and hurt themselves, injure themselves. The other thing he noticed that was when patients started using medical marijuana, they were able to stop other drugs like Haldol or Risperidol, various forms of antipsychotics and sedatives. And we know, I think many of us, how tempting it can be to prescribe and overprescribe drugs in older adults. So the idea that marijuana could not only provide some relief and calming effects, but could also help people get off of some of these drugs that have side effects of their own, that seemed to me to be a huge potential win.
You have talked about using marijuana or some of the compounds from marijuana to treat very hard-to-treat conditions. And you also mention a person who found it helpful for PTSD, post-traumatic stress disorder. That, too, can be very difficult to treat with other medications. Can you tell us a little bit, please, about Tomas and his experience?
Sure. That was both a very sad story, but also a success story in the marijuana playbook. Tomas was a young man in his 20s who had survived a really harrowing kidnapping just a couple of years before I met him, had awful PTSD as a result, went to multiple psychologists, psychiatrists, was prescribed numerous medications, all of which made him feel sleepy, out of it, disconnected, but didn't help to alleviate the panic attacks that he was having, didn't alleviate his nightmares, and didn't let him sleep any better. By the time he finally turned to medical marijuana, was on a list of 8 or 9 different medications he was taking around the clock, was really miserable, But with the help of medical marijuana, he says, he was able to stop taking all those medications, felt better, was able to go back to work. It was really life-changing for him. I should note that this is a recurring theme. There are no, to my knowledge, randomized controlled trials showing that marijuana in any form is effective in the treatment of PTSD. But given how many people are using it, and given how many people are turning to medical marijuana for the management of PTSD because other drugs haven't worked for them, that's an area in which we really desperately need research, because a lot of people are swearing by it, and we need to figure out whether it works.
Dr. David Kasserit, would you share your own experience with marijuana? I mean, this was an experiment. How did that go?
It went well, I guess. It was an interesting experience. So about midway through writing the book, I had become convinced that there probably really were some medical benefits to marijuana, probably not as many benefits as its most ardent proponents claim, but more benefits than many physicians, honestly, would like to admit. And so when I suffered a severe acute back injury, as many people nearing or in middle age have been through, it's one of these episodes where suddenly you find yourself on the floor. 5 seconds ago, you were fine, and all of a sudden you have the most horrendous, wrenching back pain you can imagine, unable to move, unable to breathe. The spasms are so bad. Many people have been through that, and if you have, you know how awful it can be. And it was at that point in writing the book where I was starting to be impressed by some of the medical benefits, and I thought it would be a great opportunity for a little bit of self-experimentation. And I gave it a try. And I think the interesting thing to me was not so much whether it helped, and it did. It definitely relieved some of the muscle spasms, allowed me to get some rest, and loosened up some of those muscles that got me up and walking around again. But really the side effects and the fact that I didn't really know what I was doing. I'm not a recreational marijuana user. Didn't know what I was doing, didn't know how strong the stuff was that I was smoking, and so smoked far too much, wound up with visual hallucinations of dancing patio furniture, auditory hallucinations of air traffic controllers in my living room, neither of which are particularly dangerous or scary, but definitely not something you'd want to experience. And so the lesson there for me was not so much whether medical marijuana works for acute back injuries, but the argument that for people who start using it medically, especially as in my case, if you don't know what you're doing, it really pays to have some guidance, some education, some advice, and it really pays to know what's in what you're smoking. What are the THC concentrations in particular? What's the strength? What's the potency? And what's a reasonable dose? And how can you dose yourself in a way that will provide some relief without the hazards of seeing dancing patio furniture all around you?
How would you learn the strength, the potency, the appropriate dose of marijuana if you're smoking it? Is it different if you're ingesting it in some other way? And how many different ways can people get marijuana that they're using medicinally?
Sure. So all great questions. Maybe the first question first, how would you know? Some states now, Colorado chief among them, have laws that require that any medical marijuana that's sold needs to be tested, both to make sure it doesn't have contaminants like bacteria or pesticides, but also so people who are buying it know what the concentrations of the chief cannabinoids are, THC main among them, because you want to know how much THC you're getting so you can begin to titrate the effects. Not that THC is the only effective cannabinoid, but you really want to make sure that you're not getting too much. So when you go to a reputable dispensary in Colorado and other states, you can be told that this is how much THC is in this square of chocolate or in this brownie or in this joint, so you know what the strength is. And just in joints alone, the strength in what's available commercially, both recreationally and medically, varies widely. Some joints have THC concentrations of 2%. Some joints have concentrations of 20%. And that's a huge variation. It's important to know what you're getting.
Okay, so is there a best way to take marijuana?
So there are lots of different methods of getting the active ingredients of marijuana, THC and CBD chief among them, into you. Smoking is by far the most venerable, tried and true. And many patients I've spoken to swear by smoking because it's cheap, it's easy, it's relatively simple and straightforward, and it gives people a sense very quickly of how much relief they're going to get. So if you take a puff on a joint, the THC levels in your blood will reach their maximum point within a minute or two, and you start to feel the effects. People do within 10 or 15 seconds. So people who want relief from conditions like neuropathic pain, sometimes severe nausea, want relief quickly, but they also want to be able to titrate those effects. So smoking for them is often the best method. A version of smoking, which is becoming a lot more popular lately, is called vaporizing, which uses the same principles of vapor cigarettes, for instance. You heat a piece of a marijuana flower to a temperature that's hot enough to get THC, CBD, other cannabinoids to turn into vapor that can be inhaled, but not so hot that the marijuana flower itself starts to burn. So you get the benefits or the effects of THC and CBD without inhaling the smoke and tar and particulates of what you would get if you smoke a joint. So for people who want relief very quickly and want to be able to titrate, those forms are useful. Many people, though, swear by edibles for other conditions like insomnia or improved appetite, where you really don't want that spike in effects very quickly. You want a much more slow, drawn-out effect. So a piece of chocolate or a brownie, other forms of edibles, which include cannabinoids, THC and CBD, dissolved into either alcohol or butter and then mixed into cooking. So there's probably no single best way of getting those active ingredients into you. It depends partly on personal preference and partly on what you're looking for.
Dr. Kasser, one of the things I like to ask when we're talking about a treatment is, what are the known side effects? What do we know about the safety of medical marijuana?
It's a great question. And unfortunately, we don't know as much as we should. Most of the studies of long-term safety of marijuana use have been done in recreational users. And those studies have generally been pretty thorough. The problem, though, is that those studies are in sometimes different populations. And those studies often are in people who are using other drugs. So it's very difficult to say, for instance, based on studies of people who use recreational marijuana several times a week for 10 or 20 years, often with alcohol and other legal and illegal drugs, to say anything meaningful about those risks as applied to, say, a 34-year-old administrative assistant who uses a square of chocolate twice a week to help her get to sleep. So with those caveats, though, there's some risks that are very clear, very obvious, driving chief among them. Based on my own experiences in researching the book and spending a fairly scary morning in the car of one of my patients, sitting next to him in a deserted parking lot of a middle school outside of Philadelphia, he fired up a joint and got behind the wheel, and his driving skills were severely impaired. And we did that not just as a stunt, but I wanted to convince him that marijuana impaired his driving just as much as drinking did.
So you set up a banana obstacle course. And what happened to those bananas?
They all met untimely ends. Those bananas did not do well. So certainly a risk of driving is significant. Anybody who would think twice about driving while under the influence of alcohol should be equally concerned about driving after using marijuana. Other risks are probably more speculative. One of them, though, which I've gotten to be more impressed by than I was when I first started researching this topic, is addiction. I never really thought that marijuana was addictive, certainly not addictive in the same way that cocaine or heroin are. But it turns out that marijuana is addictive. You can develop a withdrawal syndrome when you stop using marijuana. Those symptoms may not be as severe or as prolonged or as life-destroying as, say, addiction to heroin is, but they are significant, and it's something that patients should be counseled about.
Dr. Kasser, as a physician yourself, what would you like to tell your medical colleagues who may be unfamiliar or uncomfortable with medical marijuana? What would you like them to know?
I guess the most important thing I'd like them to know is that 2 years ago, I was also uncomfortable. 2 years ago, I thought the idea of medical marijuana was a joke. And I've begun to see some of the benefits, also some of the risks. And I've really begun to think of it more as an herbal medication that is often different forms, different places, different sources, but which has real medical benefits. I guess if I could be allowed one other piece of advice for my physicians is this is not something that as physicians we can ignore. This is something that our patients are increasingly turning to. So if you're not asking your patients whether they're using it, you're missing opportunities to learn from those patients, you're missing opportunities to educate those patients, and you're missing opportunities probably to collaborate with your patients to find what works for them. Because whether you know it or not, patients are turning to medical marijuana, and we need to be part of that team rather than being in denial.
Dr. David Casseret, thank you so much for talking with us on the People's Pharmacy today.
Oh, it's been a pleasure. Thanks so much.
You've been listening to Dr. David Casseret, professor of medicine at the University of Pennsylvania Perelman School of Medicine. He's also the director of hospice and palliative care for the Penn Health System. Dr. Casseret is the author of an earlier book, Shocked, Adventures in Bringing Back the Recently Dead. His most recent book is Stoned, A Doctor's Case for Medical Marijuana. Dr. Casseret recently launched MarijuanaResults.org, a platform for medical marijuana users to connect about their experiences and a source of data for medical professionals. You'll find a link from our website.
Lynn Siegel produced today's show. Al Wadarsky is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream, with 20% urea for extra skin protection. The number is 800-345-7339, online at uttercream.com.
If you would like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can do so by calling 800-732-2334. Today's show is number 1027. That number again, 800-732-2334. Online at peoplespharmacy.com.
When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your own experience and your thoughts on today's show. If you wish, you can tell us about your own experience with medical marijuana.
At our website, you can also sign up for our free online newsletter or the free podcast of the show. You need never miss another People's Pharmacy program, and you can share it with a friend. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
This country was built on a distinctly American work ethic. But today, work is in trouble. We've outsourced most of our manufacturing to other countries. And with that, we sent away good jobs and diminished our capability to make things. American Giant is a clothing company that's pushing back against this tide. They make a variety of high-quality clothing and activewear, like sweatshirts, jeans, dresses, jackets, and so much more. All made right here in the USA, from growing the cotton to adding the final touches. So when you buy American Giant, you create jobs for seamsters, cutters, and factory workers in towns and cities across the United States. And it's about more than an income. Jobs bring pride, purpose. They stitch people together. If all that sounds good to you, visit American-Giant.com and get 20% off your first order when you use code STAPLE20 at checkout. That's 20% off your first order at American-Giant.com with promo code STAPLE20.